Thanks. Well, we're at New England HIMSS, we're grateful to all of our supporters, members, and sponsors. And I want to give a special appreciation to the sponsor for tonight's event, NRS Global Partners, which is a provider of healthcare consulting, HIT integration services, and management solutions to the healthcare industry. And I will invite Managing Director John Ferry up to introduce our speaker for the evening.
Thank you, Craig. I guess I ought to stand back here a little. All right. Our organization is very happy to be here. There's a few other representatives, Heather Coyne and Garrett Murphy, joining us. And we are fairly new in terms of our involvement with the HIMSS organization on the local level here. And we got involved for two reasons. We came to the meeting last fall and found it very beneficial for everyone who participated from our organization. But the other reason that we decided to get involved, especially with this meeting, was when we saw the topic of challenges of health systems integration for CIOs. Any opportunity to introduce a CIO to the audience is certainly a fun one. So, very pleased to be here. I'm sure many of us out here are in technology, and if you've followed some of the comical past and discussion threads about the life as a CIO, it's been compared to that of a career in the NFL. Not for long. And certainly when you factor in what's happening in our world today and a lot of the challenges and opportunities within healthcare, the role of a CIO is a very critical one to the organization. I had the opportunity of meeting Scott a number of years ago, so I was very excited when I saw his name as the guest speaker. And Scott certainly goes against the grain in terms of short career as a CIO and IT leader in organizations. We have the privilege of hearing from someone tonight who, is just finished up his term as national chair for the National HIMSS organization. He's been involved with the organization for many years. Former CIO of Newton Wellesley Hospital here locally, and now the Deputy CIO at Partners Healthcare System. And without further ado, Scott, please join us.
Thanks, John. Thanks, Craig and Mary. Thanks for inviting me. Good evening, New England HIMSS. It's great to be back with you all. It's a terrific evening to be together. Some of you, it's interesting. I don't think I've ever been, as a CIO, compared to NFL. I'd like to think that maybe we treat our wives and children a little better, even under all the stress. I see now that both gubernatorial candidates have come out against Roger Goodell, so they're on the same page. Well, it is terrific to be back with you all. I don't know if everyone in the room knows, but for the last 4 years or so, I've been sort of your representative to national. I was elected to the national board 4 years ago, and then, as John said, had the privilege of serving as board chair this past year, which is really a fabulous experience. And I'd love to talk to you guys more after the event or anytime about how wonderfully our society is doing. In the time that I was even on the board, there was great expansion in the areas of media and analytics, our international businesses. And then also, if you caught it, just this past annual conference, we announced a consumer initiative. And this is really aimed at engaging patients, getting out of the hospital provider vendor zone that we've been in, and setting up a different business unit to be able to focus on consumer engagement, because we believe that intersection of technology will be very important for consumers as we all utilize technologies like that in the future. So I'd like to ask before I get started, how many physicians do we have in the audience? I always pick on physicians, so I'd like to, one, okay, wonderful, I love physicians. Other clinicians, nurses, great. Any other allied health professionals? So let me just say thank you, particularly to our physician and other clinician friends. You guys are the root of the system and a really important resource for us, and the contributions you make and the sacrifices you make are just wonderful. And today's healthcare is a little bit challenging. So I wanted to say to you all that I've been to many of these events, and it's been a long day, and I don't want to PowerPoint you guys to death. I have now 7 slides left, and the last one is a slide about engaging you guys in discussion, which I think we can have with a room this size after I make a few comments. So I wanted to go through and talk about what's really going on in our healthcare system, both here in America and through the travels that I've had with HIMSS in other parts of the world. And these are the questions that Craig gave to me, so you can read through those and I'll try to address them. You'll find I really address them from a business perspective as opposed to too technical of one. So if you are a really technical person, I can hook you up with some of the technicians we have back at Partners to talk about that stuff. But I think that the business parts are really important. So I will try to make this pretty simple. If you get nothing else out of tonight and you fall asleep right now, the main message I have is, just like many things in life, follow the money. Healthcare integration happens because of the payment system and where patients go and need to go and how providers need to get paid. So that's my main message. The other thing is I wanted to give the disclaimer. There are some Partners folks in the room. I've worked for Partners for the last 17 years, which is both good and bad. I love Partners. It's a great place to work, but I also haven't been out much in the last 17 years. So the things I'm going to talk about, we've been very fortunate to have the funding and also the talent to be able to integrate our physicians and our hospitals, ambulatory practices, and even non-acute. And I realize that that's not the case everywhere in the Commonwealth. They're certainly not in the country. But there are other ways that people are doing things, so this is one lens on it from my perspective. So what really is going on in the world? And you hear these trends all the time. We really are getting wealthier, not just in the US, but around the world, and people are expecting to live longer. And as a follow-up to that, because of our great medical care here and elsewhere, people are living longer. And we find that in our biggest group of people here, the baby boomers that I'm on the tail end of. And we hear that story a lot, where our demographic is getting bigger and the resources are getting smaller. We also still have, even in this country, we have quality and access issues. You hear this regularly touted from our politicians and more serious reports from the Institute of Medicine and other organizations that are looking after how we can do things better here and in other places. As I've traveled with HIMSS, I've had a great privilege of being able to go not only around the US, but also to Saudi Arabia and the UAE, to China and other parts of Europe. And it's very interesting. We all know that the policies and the payment systems are different in comparative healthcare systems around the world. But it is really true that everybody has the same problem. Everybody is dealing with quality issues and cost issues. And everybody believes that technology, at least, is an enabler of solving those problems. And so this is the area where HIMSS is really focused. Our society is really focused on being a broker, being a place where people can compare notes and use resources to be able to bring technology to bear to make healthcare better. What else is happening? I still believe that the US, we're not the only ones, but the US is really a world leader in medical procedure development, various forms of research, drug development, medical device development, all those sorts of things, and the education programs. But we've really, as we know, been focused on specific problems at individual levels, and we've also had some focus on individual aspirations. And I don't want to cast aspersions on any one particular group, but you know in the reimbursement system that there are haves and have-nots. And I was just listening to a lecture on the way over here about those of us who have worked in provider networks know that we subsidize less reimbursed services with higher reimbursed services. And this creates different inequities in how we deliver care in terms of access and be able to cover those things. So People know all about the HITECH Act, as we've been wrestling with Meaningful Use Stage 1 and now the difficulties with Meaningful Use Stage 2, and then the subsequent Patient Affordable Care Act. So I would submit that some of what's going on here is these are a result of perhaps our industry not policing ourselves as well as we could. Most professions police themselves without heavy government regulation, at least at the federal level. And so this is not a perfect outcome, perhaps. You may have different feelings about how the HITECH Act went and how the Affordable Care Act is going, and I'm not here to either praise or disdain either one of them. It just happens to be what we have. And while they're not perfect, we are in the process of adopting electronic medical records, and we are in the process of digesting the Affordable Care Act. And I think probably people know that perhaps one of the more interesting things about the Affordable Care Act is it left the Secretary of Health and Human Services lots of discretion to pilot programs through CMS to be able to experiment with different payment systems. And I think this is where we're seeing the fundamental change in our environment. All right, so how does the healthcare system integration affect CIOs and our teams? So the landscape, and this is where I really wanted to focus on the payment system, because this is really what makes people change their behavior, at least for now. So it really means that we are affected, whether it's physicians, hospitals, non-acute care, all across the landscape. And of course, this affects the payers and the patients and everyone else working around the system. So because of this change in the payment system, the imperative really is for CIOs to do a lot of tall orders. So we're supposed to integrate all of these things, and those of you who are working in specialty care or non-acute recognize that the HITECH Act did not provide incentive for some parts of the healthcare system to adopt records. And these integrated EHRs were also supposed to go beyond that and have lots of other databases and registries for high-risk patients. These things are very expensive, and it's hard sometimes to find talent to be able to create all these things. And that, of course, is for the use of managing populations and being able to stretch our healthcare dollar more fairly over a group of folks. At the same time, while we're growing organically, there are different demands on the healthcare system. We're also expected to lower unit costs. That's what I'm faced with a lot in taking care of the infrastructure for partners. We keep having demand for more servers, more storage, more telephones, more computers, more mobile devices, but that unit cost has to come down in order to fit into the envelope that society has given us for reimbursement. Then if that isn't enough, put on top of it, we need to be very careful about security and privacy, and we certainly see what's happening with other industries and within healthcare about when we don't take that seriously or don't have the money or the will or the practices amongst the people to take it seriously. So I know at our organization, our CIO, Jim Noga, is very focused on many things, but never fails to mention security and privacy in one of his sentences to us. So this is a very tall order, and this is different perhaps than it has been in healthcare IT over the years. It really requires a focus on business, and sometimes that's a nasty word within healthcare, but there's a lot about dollars and cents here, and we need to be efficient about it. In organizations that CIOs lead, there needs to be a lot of technical excellence and precision. And in a lot of cases, I think we find, and this really isn't new, advocating for funding amongst hospital and physician practice budgets that are really stretched. And we are finding that, notwithstanding what the Globe would say about us, we are finding it very difficult to make ends meet, especially with, you may have read about the difficulties with neighborhood health plan and the successes with some of the medications that are being distributed, but how costly that is and unplanned for us. And then I put down knowledgeable human capital. Human capital is kind of cold, but good people really need good people, and you all know how difficult it is and how important it is to find and retain really good people. So I wrote down a couple things here that this is, healthcare IT is no longer your grandfather's healthcare IT. It's different. We have to be on top of our game. It's a business focus or die. and that it can't just be good enough anymore. We really are looking for excellence in all of our people that contribute. You know, labor is a huge cost in what we do. So, all right. So how do we link EHR systems? And I've been to many New England HIMSS events, so there are a ton of people in the room that can link EHR systems for you and sell it to you and tell you all about it. So I'm going to leave that for them to do. But as I said before, there really needs to be a business and clinical focus. And I don't mean to overdo the business focus, but you know, we've known for a long time, whether it's within our organization or yours or anyone else's, that there are a lot of difficulties with handoffs between care, whether it's in the hospital or between ambulatory and hospital or non-acute, wherever it is. And so there obviously is a patient safety driver here, an importance in the continuity of care. But really what I think has happened is over the years, we know in the past that healthcare, hospitals or physicians or integrated delivery systems have really wanted to hold on to patients. And so we've tended to not share information between each other. And then our beloved vendors, I'm sure there's some in the room, especially big healthcare IT vendors, want to sell all of your wares into one organization and keep the others out. So what's happening, obviously, with the changes in the payment system is we are getting religion about paying for health instead of for procedure. And that is going to cause providers of all types to want to share more information. Put the High-Tech Act on top of that, and the vendors obviously are also being incented towards interoperability. Still have a long way to go, but this is another area where our society is really focused on interoperability and advocating for it. HIMSS and RSNA were the founders of the IHE, Integrating the Healthcare Enterprise, and continue to move on that work today. And as you know, if you've been to the annual conference, we spend a lot of energy on the interoperability showcase and having a place where vendors can demonstrate interoperability between their systems. And then if you haven't seen it, there is also, HIMSS just opened an innovation center in Cleveland, Ohio, near the convention center, which is basically a permanent interoperability showcase where vendors can come and bring their customers, and folks from the provider community can see things demonstrated around the calendar year. So is Bob Dichter here? No, Bob's not here yet. Darn, shoot. Well, so. Yes, we love Bob. If you don't know Bob, you should meet him. So Bob's been around the chapter a long time, and many people in the room have. And we, for the better part of 15 years here, have been talking about, do people remember the TEPR conference, towards the electronic patient record? We've been talking about this stuff for a long time, and Bob's been a big advocate for it. And I always told Bob, I said, Bob, it's not about the interplanetary medical record. We integrate systems because we care about people, not because we want to have this great system that covers care everywhere. So again, it gets back to the clinical and business need for pushing systems together. And I think we're beginning to have more and more of that. But it's, I think we can't be in a place where we just don't have the funding and we have all sorts of privacy issues and other things that prevent us from being in that place where we say, boy, we have a national healthcare information network today. I think we're moving towards that, but we have to focus locally and solve individual problems and let clinicians do their work locally. So I would say about this, I mean, there are some barriers around standards, but generally technology isn't the barrier. We are now in this place, as I've said, where our reimbursement is being paid for health, or at least it's moving towards that direction as opposed to individual procedures, so I think that will help. And we still have a host of privacy and security issues to work with. Here in the Commonwealth, many people in your systems or hospitals, you have various vendor products that you're using to integrate yourselves. We have the Mass Highway, which has been launched and has some very good funding through the state to be able to integrate practices and hospitals. And then, of course, there are vendor solutions. And I'm not here to talk about specific vendor solutions, but there are myriad out there that you all probably are very familiar with. So Craig's next question was, how do we exchange healthcare information? And following my non-technical theme, I said not very well and efficiently. We have tended to focus on provider preferences rather than the patient. And this is with apologies to the physician and the nurses in the room. I think our clinicians really do want to be focused on patients and have their best interests in mind. What we found, and I just would cite the example of what we've been going through at Partners, we're obviously adopting a very large new electronic medical record system. And what we've found is that we believe that the collective work together in the system across the care spectrum and across disciplines is more important than the specific individual workflows of any given discipline, much to the annoyance of some of our academic physicians, as you can imagine. So we're still working through that process. But it was kind of funny when we found out we did an exercise to talk about really what was different about the internal systems we developed versus the vendor we were going to. And you guys won't be surprised to find out there was a huge delta between that. But it does mean that people need to be focused on the whole, on the patient, versus on their individual workflows, and that requires some adjustment. So socialist or communist or whatever you want to call it, this ACO model really is people working together. And again, the construct is we're a pioneer ACO and we have some leverage over people contributing to our pioneer ACO. But in some cases, the ACO model crosses business boundaries, of course, right? And so the notion here is that you really are doing what's best for the patient and then dividing the pot of gold afterwards. And I think that's a real difference. I think that means a difference in mindset and practice. John said that I was CIO of Newton Wellesley for several years, and during that time we were going through an electronic medical record adoption. And those of you who have done this with ambulatory physicians and specialists know what some of the reactions you get from those implementations. And there were not just threats about retirement, there were actual retirements. So some will choose to opt out of this next generation of how we do it. But I think between the federal mandates, and maybe they'll be modified over time, and the business case for healthcare and how we want to be treated as patients, that we will eventually get towards that National Health Information Network. But I think it is more organic than it is perhaps top down from a federal level. So what solutions do we need as healthcare organizations to accomplish the goals? So you can have lots of great technological solutions. Again, there are vendors that provide them. But really what I thought we need are very good project managers. We need people who know process improvement and workflow, clinical workflow, those who are comfortable in the healthcare environment, which I believe can be learned. I think other industries can also put their shoulder into this. And then partnership with solid vendor relationships. I think it's not just we can't do it on our own, but there are great products out there that can be integrated. In our case, we need software engineers. We're lucky to have a bunch of them. We're going to need fewer, I lament, when we finish our implementation here than we have now. And then you also obviously need security and privacy experts. We have a lot of discussions about being able to give our physicians, our academic physicians and researchers freedom in use of data, but to use it appropriately and securely. And so there's always a trade-off there. And then, of course, I think we need business savvy, keeping ourselves, and again, if we're focused on CIOs and their teams, focused on how technology enables the business as opposed to being in it for the bits and bytes. So that's what I had, and what I wanted to do is just open this up for discussion a little bit. And so wanted to think about what your thoughts and experiences have been about this subject. Do you think I got this right, or do you think I'm way off base? And then maybe some people can talk about what they believe, how this should go as a patient, or if you're a provider or a vendor or consultant. And I think the best way to do it would be, if you have a comment, try to stand up, say who you are, and speak as loudly as possible, because you won't have the microphone, but I'll try to repeat the questions or comments for people. Rich?
I'm Rich Kubica, Hartford Region CIO from Hartford Healthcare, and we're going under a similar experience, and we are going through the processes to standardize healthcare. And one of the things that we're finding is, by going through the process, a lot of healthcare is standard these days. It's not as specialized as you mentioned, the academic physicians. would like to have it be for most of your common stuff. And I think that's one of the areas where we're going to find a reduction in cost and higher quality care as we implement those standard practices. So I think when you're talking about implementing electronic health care records, I think there's a realization of the clinicians, as well as the IT people that have to deliver it, that that's where it's going. And I have a daughter who is just a brand new doctor.
Yay.
And she understands it, which is really intriguing. So, the new physicians coming in embrace it, and it will be, unfortunately for us slightly older people, tedious. So, I don't know how other people feel about it, but that's, what we're doing with Hartford Healthcare, and that's what we're finding with our implementation.
So for those who may not have heard in the back, Rich's general comment was that apart from real academic specialties, physicians are getting more used to order sets and more standardized care, and adjusting to that. There are younger physicians that are coming up and being able to cope with that, and that you think that that's an area of where there'll be cost savings. Other comments? Yes, I can't see that far back, but if I know you, hi.
Chris Hall with Clickview. Scott's on my Patriots station. That's not my fault.
we can still get you.
So I think, two things. I think you hit the nail on the head with the project management piece. I've seen it time and time again as a vendor, just as an innocent bystander on projects that it's the right technology, the right people, and a project manager that just is no different. It's no project manager. So good job on that. As a patient, what I'd like to see is my physician not seeing 22 people a day. So I feel like I have 11 minutes with them. Unfortunately, I haven't had many health problems, but I'm worried about my family and my extended family when we do. Because I think Massachusetts has the highest number of patients per physician per day, and given the expertise of this area, we should have figured out that problem sooner. So just a little bit of hope in my voice that number goes down.
Thanks, Chris. Could everyone hear what Chris said? Yes, he nods. What is it specifically about project managers, Chris, that you think they do well or should do well?
I think they're the key to the ingredients when you bring them into the kitchen to make that dinner, right? So without the project manager, it sounds like we'll ourselves now. So I think they're one of the most important pieces of any project, given the drive and the foresight that they have when projects are either going down the wrong path or the right talent's not in place. They can make those maybe not decisions, but they can adjust their blinders, so to speak, and make sure everyone has a vision on where the project's headed. But some of the projects that we see now, you guys know, and partners, they're in the hundreds of thousands of dollars versus $1 billion. You have a couple of bad project managers on projects that are $1 billion, you have huge problems. So
Amen to that.
what's that?
I say amen to that.
Yeah.
Well, I can see at least 4 partners, project managers in the room, so I recorded you, and I'll be sharing that next time funding questions come around. What else do people want to comment? Yes?
My name is Susan Campbell. I'm a nurse and a health informaticist, and for 2 years, 2.5 years, I've been working on the ONC's longitudinal coordination of care project, and also before that, transitional care project, as well as Prairie Health. And you talked at the beginning of your speech about coordination of care, continuity of care being a very important central element. I'm also a case manager. I was there because I'm a nurse case manager and because I have worked with individual patients through that continuum of care on the payer side. And I think one of the things that we are plagued with is reinvention of the wheel. We have providers who believe they know everything about healthcare, And therefore, it has to start with them. While at the same time, we have an entire huge array of people on the payer side who know all about disease management, all about case management, all about coordination of care, and those people are nurses. And we're just letting that information go by the wayside and reinventing it. It's a mammoth waste of effort. Meanwhile, the IT systems don't talk to each other, not in the simplest way. We're still trying to do things like report syndromic surveillance information and can't do that because the mass highway breaks down, or you don't have your on-ramp, or your EHR vendor requires you to pay an arm and a leg for a HISP. And Lou